Hello everyone, today we'll be talking about glaucoma. What is glaucoma? So basically glaucoma, it's not a single disease process, but it's a group of disorders that is characterized by a progressive optic neuropathy that results in a characteristic appearance of the optic disc and a specific pattern of irreversible visual field defects that are associated frequently but not invariably with raised intraocular pressure. So, what we mean is that they're frequently associated with raised intraocular pressure, but there may be some cases in which you may have normal intraocular pressure and still have glaucoma. Therefore, intraocular pressure is the most common risk factor, but it's not the only risk factor for development of glaucoma. Consequently, the term ocular hypertension is used. So, maintenance of intraocular pressure. The intraocular pressure refers to the pressure exerted by intraocular fluids on the cords of the eyeball. So, the normal intraocular pressure varies between 10 and 21 millimeters per curie. The normal level of intraocular pressure is essentially maintained by a dynamic equilibrium between the formation and outflow of the aqueous humor. Then we've got various factors that influence intraocular formation, and they can be grouped under local factors and systemic factors. So under local factors, we have got rate of aqueous humor production, rate of aqueous formation influences intraocular pressure levels. Resistance to aqueous outflow, basically we're talking about the drainage of aqueous humor. Increased episcleral venous pressure may result in increase of intraocular pressure. So basically the Valsalva maneuver causes temporary increase in episcleral venous pressure, and that leads to a rise in intraocular pressure. For dilatation of the pupil in patients with narrow anterior chamber angle may cause rise of intraocular pressure owing to a relative obstruction of the aqueous drainage by the iris. So basically what happens is if this dilation of the pupil, that leads to relative obstruction, right, of the aqueous drainage. So that also leads to an increase in intraocular pressure. 5. Refractive errors. So they said myopic individuals have, so these are basically short-sighted individuals. They have higher intraocular pressure as compared to emmetropes and hypermetropes. In fact, intraocular pressure correlates with axial length. And I don't know if you have noticed that they say that people that are short-sighted, the axial length is reduced. General factors, so these include heredity. This influences intraocular pressure possibly by multifactorial modes. Then age. So the mean intraocular pressure increases after the age of 40 years, possibly due to reduced facility of aqueous outflow. Then we go to sex. So basically, intraocular pressure is equal between the sexes in ages between 20 to 40 years. However, in older age groups, there is an increase in mean intraocular pressure with age greater in females. So between 20 to 40 years of age, the intraocular pressure is usually the same. However, after the age of 40 in females, it's greater. Then for diurnal variation of intraocular pressure, so usually there is a tendency of higher intraocular pressure in the morning and lower in the late evening, and which they have associated with the presence of plasma cortisol levels. Then postural variations, intraocular pressure increases when changing from the sitting to the supine position. Seasonal variations, intraocular pressure is higher in winter months. Blood pressure, so basically it does not have long-term effects on intraocular pressure. However, prevalence of glaucoma is marginally more in hypertensives than in normotensives. And then 8. Osmotic pressure of the blood. Then 9. General anesthetics and many other drugs also influence intraocular pressure, such as alcohol may lead to a reduction of intraocular pressure, while tobacco, smoking, caffeine, and steroids may cause a rise in intraocular pressure. And there are a lot of anti-glaucoma drugs that lead to a reduction in intraocular pressure. Then 10. Exercise. Strenuous exercise lowers intraocular pressure transiently. Pathophysiology. Pathophysiology of glaucoma revolves around aqueous humor dynamics. The principal ocular structures concerned with it are the ciliary body, the angle of the anterior chamber, and the aqueous outflow system. The intraocular pressure level is determined by a balance between the production and the removal of aqueous humor. So aqueous humor is actively secreted in the posterior chamber by the ciliary processes by a combination of active transport and ultrafiltration. It then passes through the pupil into the anterior chamber and leaves the eye predominantly via the trabecular meshwork, which we call the Schlemm's canal, and the episcleral veins to reach the bloodstream, which is the conventional pathway. However, there is a small but important proportion of the aqueous, which is 4%, drain across the ciliary body into the suprachoroidal space and is absorbed into the venous circulation, which is the uveous scleral pathway. So if we look here, so this is basically our ciliary epithelium, which is going to secrete aqueous humor into the posterior chamber. Then through the pupil, the aqueous humor is going to go to the anterior chamber and then get to the trabecular meshwork where it is drained from. Then also remember we talked about the other 4% that's going to drain through the uveoscleral outflow pathway here. So two theories have been advanced to explain how elevated intraocular pressure acting at the nerve that damages the optic nerve fibers. Because remember in the definition we said there's what damage to the optic nerve? So one, it may be due to raised intraocular pressure that causes mechanical damage to the axons. Two, raised intraocular pressure causes ischemia of the nerve axons by reducing blood flow at the nerve head. The pathophysiology of glaucoma is probably multifactorial and both mechanisms are important. So classification of glaucoma. So how we can classify it is primary glaucoma, congenital glaucoma, and secondary glaucoma. So primary glaucoma consists of chronic open angle glaucoma and acute and chronic closed angle. Then congenital glaucoma is divided into primary, then secondary to maternal rubella infection, and secondary to inherited ocular disorders, such as aniridia, which is absence of the iris. Then there is secondary glaucoma, which may be due to trauma, ocular surgery associated with other ocular diseases such as uveitis, raised episcleral venous pressure, or steroid induced, basically drug induced. Okay. So let's talk about the pathogenesis of primary open angle glaucoma. So in open-angle glaucoma, the trabecular meshwork appears normal on gonioscopy, but functionally it offers an increased resistance to the outflow of aqueous. This results in an elevated ocular pressure. So what are the causes of outflow obstruction? Thickening of the trabecular lamellae, which reduces the size of the pores, reduction in the number of lining trabecular cells, increased extracellular material in the trabecular meshwork spaces. Then remember when we were talking about the definition, we said that you can still have glaucoma with normal intraocular pressure. Yeah, so a form of glaucoma also exists in which glaucomatous field loss and cupping of the optic disc occurs even though the intraocular pressure is not raised. So that's what we call normal tension or low tension glaucoma. It is thought that the optic nerve head in this patient is unusually susceptible to the intraocular pressure and or it has an intrinsically low blood flow. Conversely, intraocular pressure may be raised without evidence of visual damage or pathological optic disc cupping. Ocular hypertension. So here we've talked about two things. So we said that there is a chance whereby you may have normal intraocular pressure but still develop glaucoma, and this is usually due to the optic nerve is susceptible to the intraocular pressure. And there are also cases whereby the intraocular pressure may be raised, however, there is no visual damage or pathological optic disc cupping. This is what we call ocular hypertension. This is not going to be glaucoma. And this subject may represent as extreme end of the normal range of intraocular pressure. However, a small proportion, about 1% per year, will subsequently develop glaucoma. So basically, they may have high intraocular pressure, but they are not going to have glaucoma at the time. However, there is a high chance that they are subsequently going to develop glaucoma in the future. And now let's talk about closed angle glaucoma. This condition occurs in small eyes, often what we call hypermetropic individuals, which therefore have shallow anterior chambers. In the normal eye, the point of contact between the pupil margin and the lens, it offers a resistance to aqueous flow from the posterior into the anterior chambers, relative pupil block. So there is a pressure drop between the posterior and the anterior chamber. In ankle closure glaucoma, sometimes in response to pupil dilation, when the peripheral iris may be bunched up in the angle, this resistance is increased and the increased pressure gradient moves the iris forward and it closes the drainage angle. The aqueous humor can no longer drain through the trabecular meshwork and ocular pressure rises, usually abruptly. This peripheral iris contact ultimately leads to adhesions, which are called peripheral anterior synechia (PAS), which consolidate the obstruction. The severely reduced or stagnant circulation of aqueous humor deprives the whole cornea of nutrition and the posterior cornea of its oxygen supply. This causes a catastrophic failure of endothelial pumping function and a massive degree of corneal edema and clouding. This is also amplified by the raised intraocular pressure, and it results in a profound fall in vision. So, however, a full-blown attack of angle closure glaucoma may be preceded by subacute episodes of angle closure that are associated with transient rises of pressure, headaches, and the experience of colored halos around bright light. These rainbows are due to the presence of mild corneal epithelial edema, which separates the regularly arranged basal epithelial cells so that they act as a diffraction grating. Any patient presenting with a history of headaches should be asked about the presence of rainbows around lights, which are a key symptom of such prodromal attacks. So basically, what we talked about here was closed angle glaucoma. However, they said that acute closed angle glaucoma. However, they said that sometimes you may have subacute attacks, so they won't be as bad. So that's whereby there's a transient rise of pressure which may give you headaches and experience of colored halos around bright lights. So secondary glaucoma. In secondary glaucoma, the rise of intraocular pressure is usually due to trabecular meshwork obstruction. The trabecular meshwork may be blocked by blood, following blunt trauma, inflammatory cells, uveitis, pigment from the iris, such as in pigment dispersion syndrome. Deposition in the trabecular meshwork of material produced by the epithelium of the lens, iris, and ciliary body, such as in pseudoexfoliative glaucoma, and drugs increasing the resistance of the meshwork, such as in steroid-induced glaucoma. Secondary glaucoma may also result from blunt trauma to the eye, causing damage to the drainage angle, which is angle recession. Angle closure may also account for some cases of secondary glaucoma, such as abnormal iris blood vessel may obstruct the angle and cause the iris to adhere to the peripheral cornea, closing the angle. Rubiosis iridis. This may accompany proliferative diabetic retinopathy or central retinal vein occlusion due to the forward diffusion of vasoproliferative factors such as VEGF from the ischemic retina. A large choroidal melanoma may also push the iris forward, approximating it to the peripheral cornea and causing an acute attack of angle closure glaucoma. A cataract may swell, pushing the iris forward and close the drainage angle. Uveitis may cause the iris to adhere to the trabecular meshwork. Raised episcleral venous pressure is an unusual cause of glaucoma but may be seen in caroticocavernous sinus fistula, where a connection between the carotid artery or its meningeal branches and the cavernous sinus causes a marked elevation in orbital venous pressure. Now let's talk about congenital glaucoma. So the cause of congenital glaucoma remains uncertain. One view is that the iridocorneal angle is developmentally abnormal and covered with a membrane, which increases the outer resistance. So now let's talk in detail about chronic open-angle glaucoma. So the epidemiology. Chronic open-angle glaucoma affects 1 in 200 of the population over the age of 40, affecting males and females equally. The prevalence increases with age to nearly 10% in the over 80 population. There may be a family history, although the mode of inheritance is often unclear. Genetics. So, first degree relatives of patients with chronic open angle glaucoma have up to a 16% chance of developing the disease themselves. Inheritance of the condition is complex. History. So basically, when a patient comes and then you ask them for the history, so the symptoms of glaucoma are basically going to depend on the rate at which the intraocular pressure rises. So chronic open-angle glaucoma is usually associated with a slow rise in pressure and is symptomless until the patient becomes aware of a visual deficit or the diagnosis is made by chance. Many patients are diagnosed when the signs of glaucoma are detected by an optometrist. On examination, so basically in history, most likely they're going to be symptomless. On examination, in patients with chronic open-angle glaucoma, the eyes are white and the cornea are clear. Assessment of a glaucoma of glaucoma suspect requires a full slit lamp examination and it involves, so obviously you have to measure the ocular pressure using a tonometer. So in chronic open angle glaucoma, usually the pressure will still be between 22 to 40 millimeters mercury. However, in angle closure glaucoma, it rises above 60 millimeters mercury. Then measurement of the thickness of the cornea with a pachymeter and the measured value of the intraocular pressure must be adjusted according to the corneal thickness. So if we look at the corneal thickness, this also affects the intraocular pressure. So you also need to measure the thickness of the cornea. Then examination of the iridocorneal angle by gonioscopy, that is to confirm that an open angle is present. Then exclusion of other ocular diseases that may be a cause of a secondary glaucoma, such as if we look at trauma, if there is any other eye condition, you need to rule those out. Examination of the optic disc and determination of whether it is pathologically cupped. Cupping is a normal feature of the optic disc. In the normal eye, the cup to disc ratio is usually not greater than 0.4. However, in chronic glaucoma, the vertical cup to disc ratio becomes greater than 0.4. Visual field loss in glaucoma is due to the death of optic nerve axons. Field testing is used to establish the presence of islands of field loss, which we call scottomata, and monitor the progression of optic nerve damage. So, symptoms and signs of chronic open angle glaucoma. In the early stages, it's symptomless. Then you are later going to be able to see a white eye and clear cornea, raised intraocular pressure, visual field defect, and cupped optic disc. Treatment. So basically, treatment is aimed at reducing intraocular pressure. The level to which the pressure must be lowered varies from patient to patient and is that which minimizes further glaucomatous visual loss. This requires careful monitoring in the outpatient clinic, and three modalities of treatment are available. So the first one is medical treatment, the second one is laser treatment, and third is surgical treatment. So medical treatment in chronic open angle glaucoma, the prostaglandin analogs such as latanoprost or travoprost are becoming the first line treatment. They act by increasing the passage of aqueous humor through the uveoscleral pathway. And we can also use topical adrenergic beta blockers such as timolol, which may further reduce the pressure by suppressing aqueous secretion. So basically, if we look at the prostaglandin analogs, they increase the drainage. However, adrenergic beta blockers, they reduce the pressure by what? By reducing the secretion. The non-selective beta blockers carry the risk of precipitating asthma through their beta-2 blocking action following systemic absorption, or they may exacerbate an existing heart block through their beta-1 action. So pilocarpine, which is a parasympathomimic, may occasionally be used in the treatment of chronic open-angle glaucoma. If intraocular pressure still remains elevated, the choice lies between. So you can add an additional medical treatment, you can do laser treatment or surgical drainage procedures. So basically this is just a table showing the medical treatments, their mode of action and the drug side effects. So under surgical treatment we have got laser trabeculoplasty. This involves placing a series of laser burns which are 50 micrometers wide in the trabecular meshwork to improve aqueous outflow. Whilst effective initially, the intraocular pressure may slowly rise. Surgical treatment. So we've got drainage surgery, which is trabeculectomy, which relies on the creation of a fistula between the anterior chamber and the subconjunctival space. So what are the complications of surgery? So this leads to swelling of the anterior chamber in the immediate postoperative period, risking damage to the lens and the cornea, intraocular infection, possibly accelerated cataract development, failure to reduce intraocular pressure adequately, and excessively low pressure, which is hypotonia, which may cause macular edema. Now let's talk about normal tension glaucoma. Normal tension glaucoma is considered to lie at one end of a spectrum of chronic open angle glaucoma. It can be partially difficult to treat, although in those with progressive field loss, lowering intraocular pressure may be beneficial. Some patients appear to have non-progressive visual field defects and may require no treatment at all. Now we go to primary angle closure glaucoma. Primary angle closure glaucoma affects 1 in 1,000 Subjects over 40 years old, with females more commonly affected than males. Patients with angle closure glaucoma are likely to be long-sighted because the long-sighted eye is small and the structures of the anterior chamber are more crowded. So when a patient presents under history, there is usually an abrupt increase in pressure and the eyes become photophobic and very painful due to ischemic tissue damage. There is watering of the eye and loss of vision. Intermittent primary angle closure glaucoma occurs when an acute attack spontaneously resolves. The patient may complain of pain, blurring of vision, and seeing colored rainbows around lights. On examination, visual acuity is reduced, the eye will appear to be red, the cornea will be cloudy, and the pupil oval, fixed and dilated. Treatment. So the acute and dramatic rise in pressure seen in angle closure glaucoma must be urgently counted to prevent permanent damage to the vision. Acetazolamide is administered intravenously and subsequently orally together with topical pilocarpine and beta blockers. So pilocarpine basically constricts the pupil and it draws the peripheral iris out of the angle. The acetazolamide and beta blocker reduce aqueous secretion and the pressure gradient across the iris. These measures often break the attack and lower intraocular pressure. Subsequent management requires that a small hole, which is iridotomy or iridectomy, be made in the peripheral iris to prevent further attacks. This provides an alternative pathway for fluid to flow from the posterior to the anterior chamber, bypassing the pupil and thus reducing the pressure gradient across the iris. So this is basically the diagram showing the appearance of the eye in angle closure glaucoma. So you need to take note of the cloudy cornea and the dilated pupil. If the pressure has been reached for some days, the iris becomes adherent to the peripheral cornea, so it leads to the formation of peripheral anterior synechia or PAS. The iridocorneal angle is damaged and additional medical or surgical measures may be required to lower the ocular pressure. In some patients with cataract, lens extraction with implantation of an intraocular lens may help open the iridocorneal angle. Secondary glaucoma. Secondary glaucomas are much rarer than the primary glaucomas. The symptoms and signs depend on the rate at which intraocular pressure rises. Most are again symptomless. Treatment broadly follows the lines of the primary disease. In secondary glaucoma, it's important to treat any underlying cause such as uveitis, which may be responsible for the glaucoma. And in particularly difficult cases, it may be necessary to selectively ablate the ciliary processes in order to reduce aqueous production. This is done by application of a laser or cryoprobe to the sclera overlying the processes. Congenital glaucoma. So this covers a diverse range of diseases. It may present at birth or within the first year. Symptoms and signs include excessive tearing, photophobia, and blepharospasm. An increased corneal diameter and enlargement of the globe, which is both bulbous, resulting in progressive myopia, a cloudy cornea due to epithelial and stromal edema, then splits in Descemet's membrane. Congenital glaucoma is usually treated surgically. An incision is made into the trabecular meshwork, which is coniotomy, to increase aqueous drainage or direct passage between Schlemm's canal and the anterior chamber is created. So, what is the prognosis of glaucoma? So, the goal of treatment in glaucoma is usually to stop or reduce the rate of visual damage. It may be that control of intraocular pressure alone is not the only factor that needs to be addressed in the management of glaucoma. Reducing intraocular pressure is thus currently the mainstay of treatment. So, basically, the mainstay is what reducing intraocular pressure. Then, some patients will continue to develop visual loss despite a large decrease in intraocular pressure. Nonetheless, vigorous lowering of intraocular pressure, even when it does not prevent continued visual loss, appears to significantly reduce the rate of progression. If the diagnosis is made late when there is already significant visual damage, the eye is more likely to become blind despite treatment. If intraocular pressure remains controlled following acute treatment of angle closure glaucoma, progressive visual damage is unlikely. The same applies to the secondary glaucomas. If treatment of the underlying cause results in a reduction of intraocular pressure into the normal range. So basically this is just a diagram showing the progression of glaucoma. So if there is early diagnosis and there is no further glaucomatous damage, so the way you lose your vision is quite normal, quite similar to the normal eye, if you can see here. Then late diagnosis, it's here again the progression will be similar to A normal eye, however, obviously since it's started at a lower level, so you lose more vision. Then if you have untreated glaucomatous eye, you can see how fast it progresses. So by the age of 70, most likely you won't even be able to see anything. So the key points in this presentation. So basically, glaucoma is an optic neuropathy that is commonly caused by an elevation of intraocular pressure. Glucomatous optic neuropathy is distinguished from that due to other causes by an enlarged optic cup. Primary glaucoma is classified according to whether the trabecular meshwork is obstructed by the peripheral iris, which is angle closure, or not open angle glaucoma. Treatment of glaucoma relies on lowering ocular pressure to reduce or prevent further visual damage. Ocular pressure can be reduced with topical and systemic medication. Laser treatment and surgery. And beware of patients who are acutely ill with red eye. They may have acute angle closure glaucoma. So basically that's all about glaucoma. If you like the video, please like, subscribe and comment. Thank you.